Today, this is our third session in the interventional neuro techniques. We had a couple of classes on anatomy, then two classes on acute stroke and its management. Now, this is another class which is associated with stroke, but this is uh, something when done standalone is more of a prophylactic or secondary prevention, like somebody had initial symptoms or is already developed a risk factor and we are trying to prevent stroke. Somebody might not have had a primary stroke but just incidentally found to have a stenosis, or sometimes they have a small stroke or TIA, that is a transient ischemic attack, and was found to have a carotid artery stenosis. So those patients can then be given the option of carotid artery stenting. In the acute setting, it is more of a tandem occlusion that both the carotid artery got occluded and it sent an embolus up into the MCA, which has led to the acute stroke. But today we'll be focusing more on the fact when we are doing an isolated extracranial carotid artery stenting. So this is the basic idea that you have a plaque here and you put a stent across it. But whom and what to stent, which lesions to stent, which to leave, when to stent is all what we will be discussing today. So basic first, initially traditionally we used to define stroke as something which was focal neurological deficit more than 24 hours and which had a vascular etiology, like not infective or other causes, primarily vascular etiology, and something that remained for less than 24 hours was considered a transient ischemic attack. But now things have changed to a tissue-based approach, which is primarily again imaging based approach, because that's the way we figure out if something has gone, or maybe ophthalmic examination for retinal cells. So we find out that there is a sign of a definitive brain injury, like diffusion images. There should be some change which is seen. If not, and there is some dysfunction which may be temporary, or it stays. So usually those which do not have any lesion in the brain on MR will mostly recover. So those are considered TIAs. And when there is an infarction, that is, there is an area which have undergone infarction, there is some core, there is some area which is showing diffusion restriction. Or if it's, you do it late, if restriction has gone, there should be some focus which is new. So if we are able to define that, then it is called a stroke. If nothing is definable, then it is a TIA. Now, the important thing in stroke is that a large part of the stroke is ischemic stroke, while some of it is hemorrhagic stroke. So while the one which we consider cryptogenic also we include into the ischemic stroke portfolio. So ischemic stroke can be because if we can't find anything, the clot can come from the heart. The clot can come from atherosclerotic disease, like in the extracranial circulation, which could be the carotid stenosis or vertebral artery stenosis, and a plaque from there breaks and goes into the brain, causing ischemic stroke. Or it could be because there is such tight stenosis that the blood flow is restricted and you get watershed kind of stroke. So this is another known etiology. This is one known etiology, that the clot can come from the heart and then get lodged into the intracranial circulation. Whereas this part is the small vessel disease, lacunar infarcts that we call that, because maybe hypertensive patient or a very small clot, that very minor artery was gone and none of them has come from a distant source. It is developed there and itself, mostly like a small perforator which has gone. So it is this part, this 20% here, that we are talking about, this one. So this 20% is the one which is coming from the atherosclerotic disease, cerebrovascular disease, and can lead to acute stroke later on. Maybe something breaks off and goes, or because of tight stenosis, the flow is so much restricted that there are infarcts. So the one which is flow related, that there is no clot that has gone up, there is no complete occlusion, but such amount of blood is restricted that you will have infarcts in the brain. They are called watershed infarcts because of the decreased flow, and the stroke will happen in the areas which are watershed between MCA, CA territory, PCA, MCA territory, because that is the place where the collaterals are combining. They are the most distal for both the circulation, and those areas, once the blood reduces, that is the place where least amount of blood will go. So those areas get affected, the watershed territories as we know them. The other is wherever the clot goes and gets lodged, that cortical territory or that white matter territory can get damaged. So that these are the two types of strokes. So carotid artery stenosis, with the commonest site is the carotid bulb, this location here, and the proximal ICA. So this is the most common location because this is the bifurcation location, and there is a turbulent flow here. There's the jets that bifurcate here, they cause injury to the endothelium. And extracranial carotid stenosis is responsible for 20 to 25% of the ischemic strokes that we know, and this is also known as artery to artery embolism. So artery to artery embolism is, there was, say, a plaque can form in the intracranial circulation, it can form in the heart and come from there, that is cardioembolic, and it can form in one of the neck vessels, and from there some part can break and go off, that is known as artery to artery embolism. And this, treating this stenosis would be a part of secondary prevention of stroke. So now if you see some stenosis, maybe if you've done carotid Dopplers, you might say that some amount of plaque is always there, small, big, sometimes 10%, 20%, 30%. Should we start treating everything? Can any plaque go up? So for that is where the discussion comes in now. And also there has the more known procedure that has been previously seen is the uh, carotid endarterectomy. So carotid endarterectomy is also a procedure. So whether to do carotid stenting or carotid endarterectomy is another question. There is no consensus. The basic idea is you have to go with something where you can keep the complications as low as possible. There are some relative and absolute contraindications where one or the other is preferred. But when both can be done, then basically it's the center's expertise, the person who is seeing the patient, his expertise, who is more comfortable with. The basic idea is to keep the complication percentage very low. So first thing that we have to question is whether it's a symptomatic stenosis or an asymptomatic stenosis. So I got some Doppler done. Somebody felt that it might be, say CABG patient planned, just getting a Doppler done of the carotids. Risk factors are there. Patient undergoes a Doppler for carotid, goes a neck ultrasound and finds out that there is carotid stenosis. So those things are considered asymptomatically found out. Got a CT done and got detected for carotid stenosis. TT was done for something else. So that is asymptomatic part. And if somebody came with a recent TIA or recent stroke, and then in the workup we found out that the patient had carotid artery stenosis, that is considered a symptomatic carotid artery stenosis.